PVCs or premature ventricular complexes are the most common ventricular arrhythmias. They are ubiquitous. We all have them, and then we have many patients who have frequent PVCs. So it's important to understand which PVCs are the ones to be concerned about and how do we manage them. Hi, everyone. My name is Guru Kalgi. I'm one of the cardiac electrophysiologists at Mayo Clinic in Rochester, Minnesota, and an assistant professor of medicine. I'm excited to be here and to talk about our upcoming review article in the Mayo Clinic Proceedings titled The Management of Premature Ventricular Complexes in the Outpatient Setting. I had the distinct pleasure of co-authoring this with my colleagues, Dr. Andrew Singh and Dr. Christopher DeSimone. So in this review article, we go over certain clinical features. What makes PVCs challenging to manage is they have a wide spectrum of clinical presentations. So you could have a patient who is completely asymptomatic, to those that have symptoms such as palpitations, shortness of breath, fatigue, chest discomfort, to the other end of the spectrum where the initial presentation could be sudden cardiac arrest due to PVC-induced ventricular fibrillation. So how do we identify which patients are low risk and which ones are high risk? So in our description of workup, we go over how a 12-lead ECG is imperative, is a good idea to get a sense of their PVC burden with a Holter monitor and to get some kind of structural assessment, especially if the PVC burden is high with the transthoracic echocardiogram. So a 12-lead ECG gives us a lot of useful information. It gives us a sense of the morphology of the PVC, so you can try to localize and see where they are. In the EP world, we do this all the time for procedural planning, but it's not a bad idea to at least identify the common PVCs, especially those that are idiopathic or those that are present in a structurally normal heart. So these would be outflow tract PVCs, for example. So they're coming from high up in the outflow tract. So they're typically positive, tall positive in the inferior leads, in leads 2, 3, and AVF. And in the high lateral leads, AVR and AVL, they are completely negative. So if you see this combination and think of outflow tract PVCs, and oftentimes these can be seen in patients with structurally normal hearts. But beyond the morphology, it gives us a sense of the coupling interval. Now, this is a relatively new concept for many internists and primary care physicians. So we do spend a section of the article talking about this. And what it is the distance or the time from the end of the sinus QRS, a normal QRS, to the beginning of the PVC. So if you look at this example, we have a patient with sinus rhythm and then interspersed with PVCs. And we have a zoomed image here. So the time from the end of the QRS to the start of the PVC. There are different definitions, but this is the one we most commonly use. So a good rule of thumb is if this distance is less than a box to a box and a half, so 200 to 300 milliseconds or less, that is concerning. So because these are the patients that can have the PVC fall on top of their T wave and create an R on T phenomenon and induce this polymorphic ventricular tachycardia. And patients can present with sudden cardiac arrest with just benign PVCs coming at a bad time. After the ECG, you can do a Holter monitor to get a sense of the PVC burden. So if they have PVC burdens less than 5 to 10% and they're asymptomatic, these patients could purely be monitored in 6 months or a year or even longer intervals if they're completely asymptomatic. But if their burden starts going above 15%, 20%, then we worry about the risk of them developing PVC-induced cardiomyopathy. And this is an LV dysfunction, RV dysfunction characterized by dilated ventricles, and then they can manifest with symptoms of heart failure as well. So which is why for frequent PVCs, a structural assessment is important with a transthoracic echocardiogram. It's important to note that if these patients end up getting a cardiac MRI, typically for PVC-induced cardiomyopathy, they do not have a lot of scars. They'll be, the LGE pattern would be negative, and they'll have dilated ventricles with reduced function. If you see a patient who has significant scar in the presence of frequent PVCs, then likely the cardiomyopathy is not all due to the PVCs. So that's one factor to remember. Then lastly, we talk about management of these PVCs. So we have a flowchart in the article where we talk about how to manage patients depending on their PVC burden and their symptoms. So if the patients are symptomatic, then it makes sense to do a PVC suppression strategy. So you can do medications such as beta blockers or calcium channel blockers. And if they have an improvement with those, they could stay on them, or they could be referred to cardiology or electrophysiology for the consideration of antiarrhythmic drugs and or catheter ablation, depending on patient preference. Now, if they're symptomatic, but we're not sure if the symptoms are from PVCs or otherwise, We could do a PVC suppression trial. So this could be done with a drug like amiodarone. And again, at that point, it makes sense to refer to an electrophysiologist to do so. And then if we put them on amiodarone, they have a reduction in PVC burden and feel like a new person, then that gives us more of an impetus to be more aggressive with PVC management. But on the other hand, the PVCs go down, they still have the symptoms like fatigue and shortness of breath. Maybe it's time to look at some other causes for their symptoms. Now, if they're completely asymptomatic, then PVC burden becomes important. So if they are less than 5%, you could reassure them and then just monitor clinically. And if they have a change, then do an echocardiogram. On the other end of the spectrum, if they have high PVC burdens, like over 20%, then it makes sense to do a baseline echocardiogram and maybe monitor every 3 to 6 months to see if there's any worsening of the LV function, in which case it'd be more aggressive managing the PVCs. So we hope this paper gives you a flavor of how to manage PVCs, because these are so common that it's important for everyone to have an idea. We made some tables sort of highlighting the red flags in PVC evaluation, as well as the figure you saw about management of a PVCs all in one page. So we had a lot of fun writing this article. We hope you enjoy reading it and learn something from it. Thank you so much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.